Good morning. Good morning. Welcome to the Orlando GI Journal Club. This is January 8th, 2025, Eastern Standard Time. Welcome, everyone, and a Happy New Year to all. Our first study is by Miyoshi et al., published in Gut. These authors have developed the Emerald test, which is a liquid biopsy, essentially a serology test to identify Barrett's esophagus and esophageal adenocarcinoma. As everyone's already aware, I'm sure esophageal cancer is the most lethal GI malignancy after pancreatic cancer. And the progression from Barrett's to dysplasia and then to esophageal adenocarcinoma does occur slowly over approximately 20 years, and the risk is considered to be 1 to 3% per year. There is no clinically relevant serological marker for early detection of esophageal cancer to date, and also for Barrett's esophagus. And a blood-based test would complement the screening options available, which currently is EGD by gold standard. MicroRNAs are single-stranded RNAs that are regulating gene expression and cellular processes, and it's involved in the pathogenesis of esophageal cancer. And due to the stability of microRNAs in body fluids and disease specificity, circulating microRNAs are potentially promising candidates for developing non-invasive liquid biopsies. The aim of this study was to develop and test a broad-based assay for esophageal cancer and Barrett's esophagus. These authors developed the Emerald blood-based test. Emerald stands for esophageal microRNAs of Barrett's adenocarcinoma and dysplasia. So these authors identified candidate microRNAs that were of diagnostic potential using tissue-based microRNA sequencing and microarray datasets. Then they validated using 42 pairs of matched cancer and normal tissue, and then they used a machine learning model to train PCR results from circulating microRNAs from training cohorts of 160 specimens, and then tested in an external cohort. The authors identified 6 microRNAs that were overexpressed in patients with adenocarcinoma and Barrett's esophagus. So they, when they tested the Emerald test for differentiating cases of Barrett's and adenocarcinoma from controls in training and testing cohorts, they identified that the area under the operating characteristic curve in the training cohort for this Emerald test was 97.6%. And for external validation cohort, they found the area under the receiver operating characteristic curve of 91.9%. When they looked at the ability to detect esophageal cancer and Barrett's esophagus, with or without dysplasia, the sensitivity was 95.8% in the training cohort and 82.5% in the validation testing cohort. When they also looked at the specificity of this testing in non-disease control, so those without Barrett's, without dysplasia, without adenocarcinoma, the specificity in the non-disease controls was 95.2% in the training cohort and 90.5% in the validation cohort. The limitation of this study is that this was a retrospective study, and therefore further validation of this blood test is required. And the investigators, and the take-home point is that these investigators have developed and validated a non-invasive blood assay for early detection of Barrett's esophagus and esophageal cancer, and therefore this has the potential to be useful in pre-cancer screening of esophageal cancer patients in the future. Our next study is by Bichet et al., published in the Red Journal. This is looking at the factors associated with significant post-ERCP bleeding. The instance of post-ERCP bleeding has been reported in about 2% of cases in the currently available data, but the authors wanted to identify more to basically have more contemporary data on risk factors associated with clinically significant post-ERCP bleeding, as data, especially in regards to direct-acting oral anticoagulants, is lacking. The aim of the study was therefore to identify risk factors of post-ERCP bleeding and outcomes after post-ERCP bleeding. This was a multi-center prospective study involving 9 centers in Canada, United States, and Europe. They looked through prospective ERCP database of ERCPs conducted between 2018 and 2024. They included all patients who had ERCP for all indications other than ampulectomy. For follow-up period is for 30 days. And they say that for follow-up, the clinical records were reviewed by 2 independent assessors. I didn't see anything mentioned about making direct phone calls or reaching out to patients in a more prospective manner. The primary outcome was the incidence of clinically significant post-ERCP bleeding. In this study, it was defined as having symptoms or signs of GI bleeding, such as hematemesis, melena, or hematochezia, which resulted in hemoglobin drop of at least 2 grams per liter, or need for transfusion, and or endoscopy that was performed to evaluate any suspected bleeding, and or unplanned healthcare visit, and or prolongation of existing admission. The authors basically identified 8,517 ERCPs performed by 38 endoscopists in the 6-year period. They had an incidence of clinically significant post-ERCP bleeding in 129 procedures. 4,849 of these patients were classified as a higher risk group because they underwent higher risk interventions during ERCP. That included either sphincterotomy, sphincteroplasty, pre-cut sphincterotomy, or using a needle knife to access the ducts. And in this group, the incidence of significant post-ERCP bleeding was 2.3%. In patients with clinically significant post-ERCP bleeding, endoscopy was performed in 86% of patients, and transfusion occurred in 53.5% of patients. And these are the further clinical information on patients who did and did not have bleeding. Overall, the main difference between the 2 groups, if you look at these p-values, anything less than 0.05 is considered statistically significant. So as you can see, more patients in the bleeding group were inpatients. In terms of ASA class, fairly well distributed, it looks like, between 2 groups, but they had, about 1/3 of patients who were ASA class 3. Chronic kidney disease seen more commonly in significant bleeding group. There was no difference in the incidence or prevalence of chronic liver disease in the 2 groups. P-value 0.052. Procedure indication, there was some differences between the 2 groups. Looks like the most common indication for ERCP was suspected or known bile duct stones, followed by other category, and then other indications which are less common were suspected or known biliary stricture, cholangitis, and pancreatic indications accounted for a very small proportion of the procedures performed, 1.6%, in the no bleed group, 0.8%. In the bleeding group, the overall procedure time was significantly longer in the bleeding group compared to the non-bleeding group. And if you look at the incidence of intra-procedural bleeding that was observed, significantly higher, obviously, in the post-ERCP bleeding group of 10.9% after sphincterotomy and 1.6% in after sphincteroplasty. The authors then looked at the outcomes among patients who used antithrombotic medication. So they divided the antithrombotics into aspirin, P2Y inhibitors, direct oral anticoagulant users, warfarin, and use of heparin. And if you look at the incidence of post-ERCP bleeding among patients who are not on antithrombotic medication, the incidence of bleeding is 1.3%. Now, it does get significantly higher if you're on anticoagulants or antiplatelet agents. So for aspirin, the incidence of bleeding occurred in 2.8%, 7.3% on those who are using P2Y inhibitor, 7.3% in direct oral anticoagulant users, 12.9% in warfarin, and 12% in patients who are on heparin. The authors also performed a further regression analysis to look at factors associated with post-ERCP bleeding. And if you look at the adjusted odds ratio here, anything here where the confidence interval goes from anything above 1 means that it is considered statistically significant. So here aspirin is not, because even though the adjusted odds ratio is 1.2, if you look at the 95% confidence interval, it spans 1. So the factors which are clinically significant, statistically significantly associated with post-ERCP bleeding is P2Y inhibitor, warfarin, direct oral anticoagulation, such as dabigatran, rivaroxaban, apixaban. It looks like edoxaban was not statistically significant, but there were very few patients on this anticoagulation, and therefore that's probably one of the reasons why. Also, other factors are enoxaparin. The limitation of this study is that only 129 cases of clinically significant bleeding events were identified out of more than 8,000 ERCP procedures. Therefore, there is a possibility that the study was underpowered to assess bleeding in certain underrepresented subgroups, in particular patients who are on specific antithrombotics such as edoxaban. Also, the study did not examine a potential association between electrocautery settings and clinically significant post-ERCP bleeding. But interestingly, although the study was conducted in 9 centers, they say that all centers used blended current for their sphincterotomies. So that's something to consider. Next, so the take-home point from this study is that the risk of antiplatelet-related clinically significant post-ERCP bleeding may be underestimated by endoscopists. And it looks like one of the issues is that there is suboptimal holding of these anticoagulants and antiplatelet agents before higher risk ERCPs. Next is a study published by Fishman et al. In the Inflammatory Bowel Disease Journal. These authors looked at factors associated with biologic therapy after ileal pouch anal anastomosis in patients with UC. Many patients with ulcerative colitis undergoing proctocolectomy and ileal pouch to anal anastomosis develop long-term inflammatory disorders involving the pouch, especially chronic pouchitis and Crohn's-like disease of the pouch. And some of these patients with pouch inflammatory disorders may eventually require biologic therapy. So the authors wanted to elucidate the factors associated with biologic therapy after ileal pouch anal anastomosis. So this was a prospective observational study from a single tertiary referral center in Israel. They identified and were able to consent 148 patients with ulcerative colitis who underwent total proctocolectomy and ileal pouch to anal anastomosis between 1986 and 2021. The primary outcome was the initiation of biologic therapy after IPAA and looking at the factors associated with biologic initiation. So they were able to identify 148 patients for the study. As you can see, majority of patients were Jewish, with 7.4% of the patients were Arabic. In terms of smoking status, 77% patients never smoked. BMI was normal in 53% of patients. The median age at diagnosis was 21. The median disease duration was 30 years. There was 10% of patients with who had history of any other autoimmune disease. 2.7% had coexisting PSC. The median age of pouch was 18 years. These were preoperative medical treatment, 5 ASA in 88%, immunomodulators in 58%, steroids in 88%, biologics in 36%, and 16% were on 2 or more biologic medication. The most common indication for IPAA in this study was refractory UC, which was the indication in 74% of the patients. In terms of the pouch phenotype, they saw chronic pouchitis in 28% of cases, Crohn's-like disease of the pouch in 20%, normal pouch in 45%, and recurrent acute pouchitis in 8.1%. In this patient population, biologic therapy was initiated in 23% of these 148 patients. The median time to biologic therapy initiation after IPAA was 9.2 years. And this is a univariate regression analysis to look at the factors associated with biologic therapy initiation. And anything with p-value of less than 0.05 here in this column means that it was a significant factor. So if you look at the hazard ratio here, so being of Arabic descent was significant, as was past history of smoking, preoperative biological use, either one or more than one, immediate post-operative complications was also a significant factor. And they also looked at genetic factors associated with initiation of biologic therapy after IPAA. And they identified heterozygosity of NOD2 variant was a significant factor. The limitation of this study is that even though these authors looked at a very long-kept prospective database starting from 1980s, there's a relatively small number of patients that they were able to identify that were on biological therapy. Therefore, the study may have been underpowered to assess factors associated with biologic therapy following IPAA. And in this study, because of such a small number of patients on biologic therapy, a multivariate analysis was not performed, and they performed only a univariate analysis to avoid overfitting of the data. The take-home point from this study is that there are several demographic, disease-related, and surgery-related and genetic factors associated with post-IPAA biologic therapy. So physicians treating patients with UC, undergoing colectomy and IPAA should incorporate these factors in clinical decision-making. And these patients with such risk factors will require post-operative follow-up, with closer post-operative follow-up and early initiation of biologic therapy. To recap, these authors have developed the Emerald non-invasive blood assay for early detection of Barrett's esophagus and cancer in the esophagus, with potential to transform precancer screening of esophageal cancer patients. Risk of antiplatelet and antithrombotic agent-related clinically significant post-ERCP bleeding may be underestimated by endoscopists. Several demographic, disease-related, surgery-related, and genetic factors are associated with post-IPA biologic therapy. Therefore, physicians treating patients with UC undergoing colectomy need to incorporate these factors in clinical decision-making with closer post-operative follow-up and early initiation of biologic therapy. This wraps up the Journal Club for January 2025. Our next monthly GI Journal Club returns to the first Wednesday of the month, February 5th, 2025. Thank you so much for joining me this morning from Orlando, Florida. I hope you have a wonderful day, week, and year, or month rather. Thank you so much. See you next month. Bye.